Welcome to the final educational webinar as a prelude to the LGDA LMI International Conference on Complex Lymphatic Anomalies. As Lisa stated, I am Mike Kelly. I'm the Executive Director of LGDA and your host for today's session. It is my pleasure to introduce Dr. Kiersten Ricci. Dr. Ricci is an Assistant Professor of Pediatrics, Division of Hematology at the University of Cincinnati College of Medicine and Children's Hospital of Cincinnati. She serves as the Clinical Director for the Hemangioma and Vascular Malformation Center at Cincinnati Children's Hospital Medical Center. And she has a long interest in vascular anomalies and has co-authored several papers on the subject in the medical literature. Dr. Ricci will present an overview of the medical treatments of CLAs. Welcome, Dr. Ricci.
Thank you for having me. All right, let me get this set up. All right, hopefully everyone can see my screen. So like Dr. Kelly said, I'll be reviewing medical treatments in CLA or complex lymphatic anomalies. And this is a pretty big topic, so I'm going to try to keep it simple. So there will be some things left out, but we will give it a try. So just for the outline, I'm going to provide an overview of conventional treatments of complex lymphatic anomalies. I will also refer to these as CLA throughout the presentation. We'll discuss old versus new treatment paradigms for these conditions, and I'll review current non-targeted and targeted medical therapies. And at the end, I'm just going to briefly touch upon some of these potential new treatment avenues or pathways or questions that we still need to answer. So, as you guys have heard in the last several presentations in the last few weeks, that complex lymphatic anomalies are actually a group of similar but different disorders that have only really recently been recognized as distinct diagnosis. And these have a wide range of symptoms and complications that change and unfortunately progress over time. In the CLA, this includes Gorham-Stout disease, generalized lymphatic anomaly, composiform lymphangiomatosis, and central conducting lymphatic anomaly. And unfortunately, there are no curative treatments for these conditions. And in the past, the interventions were really complication-based and mostly surgical. And this was probably due to multiple factors. One of them being that we really didn't know what these diseases were. We didn't understand these diseases. These patients also present across numerous different subspecialties when they first come to attention in the medical community. And for a long time, the terminology or what these were named or what the symptoms or issues were had different terms. And we only really recently, in comparison to other diseases, had a classification system. We also, because of our lack of understanding of these conditions, we in the past didn't have any disease modifying drugs. So our medical management was really limited to supportive therapy. And so this is going to be a busy slide, but the different surgeries and interventional procedures are not as important as just showing all the different things that have been done or could still be used to tackle or to address some of the most common or most severe complications of these disorders. For example, effusions, which can be fluid buildup in the lungs or around the heart or in the abdomen. It can be drained. They can try to close off some of these abnormal channels where this fluid is leaking from. Sometimes this can be, you can have long-term positive results or benefits from this, but other times, and unfortunately it's often the case in CLA, that the fluid builds back up, and that can even occur rapidly. You can have these progressive lesions, not just in the bone, but they can be in the viscera. They could be in your abdominal or thoracic cavity. And so there are different ways, which some of them we still use to address these, such as excision, but as we know, this is a multifocal disorder. It's multiple places in the body, and you can't excise all of the lesions, or it's too dangerous to get to certain ones, especially in the spine or in the skull. Radiation has been used, or injection of chemicals, and then sometimes if it's very progressive and we're having disappearing bones or weak bones, amputation. And in order to stabilize some of these disappearing or weak bones, plates, rods, screws, or even grafts. Pain is usually due to the progression of lesions, and so those surgical or interventional procedures are often the same. And then one of the most detrimental or severe side effects or complications can be a CSF leak, which can lead to very significant dizziness or headaches, even with sitting or standing. So your activities are severely limited, as well as recurrent meningitis or infection that can develop around the brain and spinal canal. So there are certain ways that that can be addressed, but also very difficult. Not to go into too much detail, but I just wanted to bring up a little bit more attention to radiation therapy, because actually in the literature, the success rate of radiation therapy to control or halt progression of specific lesions is actually pretty good. It's about 75%. However, I bring this up because the total dose is somewhere, the number is not as important, but the total dose of radiation that often is given is similar to that's given to people who have certain types of brain tumors. And there is a lot of early as well as late side effects. And this is really concerning for children and young adults because of neurologic, cognitive, psychiatric deficits that can occur, as well as endocrine or hormone abnormalities. So we have limited use, at least in our younger population, for this. And not only that, but radiation control progression of a bony lesion, but it cannot reverse complications such as a CSF leak or spine instability that's already happened. And these are just some examples of our medical supportive care, such as compression garments or pumps or other medications, but these are also just kind of a Band-Aid for the most part. They aren't preventative, and they're only for specific indications or specific complications. And a lot of them have limited use, such as diuretics for fluid buildup. So what has changed that has actually changed how we treat patients since Dr. Gorham and Dr. Stout first, presented these cases in the literature in the 1950s? Well, in 1982, Dr. Mulliken and Dr. Glowacki actually were the first to have a rudimentary classification system that divided vascular anomalies into hemangiomas and vascular malformations. Later came along ISVA, or our International Society of the Study of Vascular Anomalies, which redid that classification system into tumors and malformations. And it is since being updated, and we still use this today. The development of ISVA also allowed us to collaborate between multiple specialties and to also come together to have ideas for research. And what came about with that was a quick and explosive amount of research for complex lymphatic anomalies. And this has helped not only our understanding of this disease, but also to find new therapies. And so this has really changed how we treat our patients. Now we look from a comprehensive approach, and we include multiple specialties, as patients often need a combination of therapies, whether it's surgery, radiation, and medicines. And we have also improved our collaboration in clinical care as well as research. And there's also been the development of vascular anomaly centers, all of which improves care for patients and their families. And it's also led to the discovery of disease modifying agents. And we've also changed our focus from trying to treat complications to trying to prevent them and reducing them, as well as improving our quality of life for our patients. So, like for any chronic disease, the management, there really should be some principles that we follow, starting with an accurate diagnosis. And then not only do we need to assess the current symptoms and complications, which does include quality of life, but we need to think ahead and consider potential future complications. One really important key aspect as well is to provide education to the to the patient as well as to their family, not only in terms of disease, but also treatments. The questions that I get most commonly after what is this and how do we treat it is, what should I expect? Or what do I need to look for in my child in the future? So really it's trying to arm them with this information, so we can contact if any issues come up. And then it's really important to listen to your patient and to your family about the concerns that they have as well, because that is very essential for creating a treatment plan and setting clear goals of that therapy. And then lastly, we need to keep reevaluating. So it's, in simple terms, it's really treat the patient, not the disease. So this has led to a different treatment strategy. And now we have systemic medications, and the goals for those medications really is threefold. So minimizing, more than threefold, because the quality of life is also one of them in reducing pain, but we want to minimize the development of new abdominal lymphatic channels, or what we call lymphangiogenesis. We want to prevent progression or invasion of these lymphatic vessels into new tissue or new areas or cavities, into new bones. We do not want it to skull, the spinal canal, or viscera or organs. We also want to maximize bone restoration from any breakdown that has done, or bone building simply. And in terms of surgeries and procedures, we absolutely still need these, and they're very important in care. But we also think of them more not as primary, but as an additive effect for symptom relief, as well as, of course, if there's complications that cannot be controlled by medications, we certainly use them. So when discussing or thinking about disease-modifying agents or drugs, categorize them into two parts. One, a non-targeted therapy, meaning what that means is it's a drug that affects kind of general cell process, such as a cell replicating or multiplying, and it's a natural death or turnover, or something just like a general inflammatory response. And two, targeted therapy, which is when a drug interferes with an abnormal signal produced by a specific mutation or abnormality in the cell. So in terms of non-targeted drugs, we use in complex lymphatic anomalies, we generally use these in a multi-drug regimen or in combination with radiation and surgery. It's really been found that there's often suboptimal responses when used alone, or what we call monotherapy. And for some of these drugs, which I'll talk about in more detail in the next slide, there's really been a variable response overall. And it's likely dependent on the type of complex lymphatic anomaly, the combination of therapies when it's used, the severity of disease, probably when it started in terms of the severity of disease. So some examples of these non-targeted drugs are, one, chemotherapy. And this is by far not an all-inclusive list, and definitely not for the chemotherapies of ones that have been used in the past. But I highlight cyclophosphamide and vincristine because these two have better data on them, and they certainly still play a role in the treatment of KLA when trying to control this disease. So calcitonin is actually a natural hormone that inhibits osteoclastic activity or bone breakdown in the body. Bevacizumab or Avastin is kind of an anti-angiogenic or development of blood vessel, has some case reports in the literature, and then thalidomide and propranolol actually have pretty much fallen out of use, but have been used in the past. The three on the right are the medications that actually have the most data in complex lymphatic anomalies, the first being steroids, the second interferon alpha and bisphosphonates. And I'll go into a little bit more detail on each of these medications. So as I'm sure many of you know, that steroids in general have some anti-inflammatory, but they can also suppress your immune system. And they actually are relatively rapid acting, especially when we compare them to some of our targeted therapies. And some of the common ones are methylprednisone, dexamethasone, but steroids have a lot of side effects, weight gain, headaches, psychological issues, mood effects, increased appetite. There's a lot of issues that come along with them when used long-term. But we do use them in control of complex lymphatic anomalies sometimes. And when we use them, we can use them in two ways. The first being that we use them in combination with some like interferon alpha or vincristine, or one of our targeted therapies like Sirolimus, which we'll talk about, while waiting for their effects, as they can take weeks to months to really see their optimal results. Generally, we try to wean steroids off within about a few months, 2 to 3 months, but that, of course, is dependent on the patient and whether we're able to do so. The other manner in which we use is steroids, because of their anti-inflammatory effect, can help reduce pain flares. Not chronic pain issues, but an acute or immediate onset pain flare that does sometimes happen. And usually we use that for just a course of a few days to 1 to 2 weeks, so it does not need to be weaned off. The second is interferon alpha, and the use in complex lymphatic anomaly was actually based on studies in cancer that inhibited cell proliferation and new vessel development. There's really lack of larger studies or even prospective studies in the literature that supports its use, but there are definitely case reports. And it actually appears most supportive in Gorham-Stout disease, particularly when used with bisphosphonate, which helps build bone, as well as some other treatments. But it does have common flu-like side effects that can last 1-2 days. And it's nausea, vomiting, severe headache, you can have fevers. A lot of patients find it intolerable, so it's limited by that. Bisphosphonates, like I mentioned, they help build bone, and its use was actually based on conditions that have this bone breakdown, like osteoporosis, multiple myeloma, which is a cancer, mostly in older adults, that has similar circular osteolytic or bone breakdown lesions, and well as people who get frequent bone fractures, whether due to diet or other disease. The most common one that we use is zoledronic acid, or Zometa. And the reports actually support not just case reports or case series, but actually basic science now research shows support for combination therapy with other drug modifying agents. And so it actually shows that when used alone, these bisphosphonates actually decrease the amount of bone breakdown that occurs. And then when used with another agent, it even augments that more. So this is a frequent medication in complex lymphatic anomalies when bone disease is present. The side effects in the short term is fever, body aches, we call it flu-like symptoms, but it is much less severe, if it even occurs, than with interferon alpha. But long-term, so we are limited to doses and how much we can use, because it is known that it can cause jaw osteonecrosis, which is literally the death of the bone in the jaw. Again, bone breakdown, which we're trying to avoid. I did not put in here, the dosing and monitoring. It's actually very different across institutions, but Dr. Jacobus and I did write some recommendations in pediatric blood and cancer, and so I provided that link at the bottom if anyone is interested. So before talking about the targeted therapy, I just wanted to review, which I know there was already a talk on a few weeks ago, the genetic mutations in complex lymphatic anomaly, because these are the genes that are mutated that actually we target when using these medications. So in GLA, it is recently been found that it is a PIK3CA mutation that is affected. In CCLA, it is this FB4 or EPHB4 receptor, as well as one case report of an ARAF mutation as well, Opposiform lymphangiomatosis or NRAS, RAS mutations, and there has been a report of Gorham-Stout with a KRAS mutation. Putting all of that together, although this is a very simplified view of the PIK3CA pathway and the RAS pathway, what happens when these are mutated is that the signal increases. And so you end up with increased blood vessel development or lymphatic vessel development, as well as increased or abnormal cell growth and proliferation. So the targeted therapies, again, these are the drugs that interfere with the abnormal signal produced by a specific mutation in cells. And all of these that I will talk about are actually off-label use in complex lymphatic anomalies. In fact, in all vascular anomalies, they are off-label. The most commonly used is Sirolimus and then trametinib and CLA. So starting with Sirolimus, this is a potent, what we call an mTOR inhibitor, or mammalian target of rapamycin. It's an oral pill or a solution. Generally in CLA, it's taken twice a day. The side effects are dose dependent. Again, there's differences in dosing, monitoring recommendations across institutions. Here's the link again to provide that if anyone's interested in recommendations. There's also a derivative, it's called everolimus, that it has more effect on the mTOR1 than the 2, and it's once daily, but it's not used as much, but it is an option for people who have unacceptable side effects with Sirolimus, and it has very similar benefits. So this just shows where Sirolimus is actually slowing the overactivation of this signal. And just to briefly hit upon it, I'm sure many have heard the story, but how the discovery, it was rather serendipitous, the discovery of Sirolimus. It actually was here at Cincinnati Children's when Dr. Adams and her group were here. And it was in a child who did not have a complex lymphatic anomaly, but did have something called caposiform hemangioendothelioma, which does have some overlapping clinical findings with KLA and abnormal lymphatics, but it is a tumor instead. But this child was, despite all of those non-targeted therapies, she ended up in multi-organ failure and was essentially dying. And at that point, the use of Sirolimus became palliative. It was thought that, you know what, let's try to get her home. And it was remarkable that this was something that she could take by mouth, and within 2 weeks, all of her blood abnormalities had essentially normalized, and she was feeling better and able to move around, and her function was already improving. And then, slowly over several months, even her leg became smaller in size, and she was functioning and finally walking and doing very well. So, going forward, there we go. So that experience actually propelled a phase 2 trial that Dr. Adams started, and it was published in Pediatrics in 2016. And this looked at Sirolimus in multiple vascular anomalies, which did include GLA and Gorham-Stout disease. KLA and CCLA actually were not defined at the time of this trial. So just a note that that's why they're not included, but some of those GLA and Gorham-Stout could possibly have fallen into that, could have been changed their diagnosis to KLA or CCLA in the future or down the road. But it did find that overall it was effective at improving disease, whether that meant their clinical functional status, quality of life, or their imaging. But it did not specifically look at Gorham-Stout and GLA. And the long-term effects still continue to be looked at. We did take the prospective data from that trial, as well as we had retrospective data on more patients of GLA and Gorham-Stout, which we wanted to combine these because of the rarity of these diseases. And when we looked at that data in combination, we found that 83% of patients who were treated with Sirolimus had improvement in one aspect of their disease, and their quality of life improved drastically, about 78%. And it's very notable that the time to their response was only about 3 to 4 months. So pleural and pericardial effusions, which is that fluid buildup that gets into the lungs or around the heart and can be life-threatening, actually improved in 72% and 50%. And what's really important as well is that none of these effusions worsened on treatment. And we also noted that none of the bone disease progressed on sirolimus either. However, this was a limited look over a few years. And so we don't know, the time span as to if bone disease progression would occur or if it would. So these are just some examples of 2 patients from that study that show the drastic improvement, one of a lymphatic malformation in the abdomen, and with no other treatment, so not receiving injection of chemicals or anything like that, or drainage of this fluid buildup of this effusion in the child on the bottom. In terms of the other conditions, so we do know that sirolimus is effective in KLA. We actually did present an abstract at ATS in Denver in 2015 that showed this as well, which they had improved effusions, quality of life, and clinical status as well. We also know, based on literature and case reports in small series, that the blood abnormalities associated with KLA improve as well. But unfortunately, there's still a higher proportion of patients that progress on therapy or are not, or the therapy does not work at all. And it just begs the question of, is it because there's a difference in the genetic mutation in comparison, to GLA, for example, which it might be because the genetic abnormality in KLA is NRAS. And we know that that is an important driving mutation that happens in cancers as well. So it just may be an overall very aggressive, and it appears to be, condition. Or, is there also a difference in the severity of disease when the drug is started, or the location of disease? Because we also know that when KLA affects the lungs, or it's pulmonary KLA, this is very dangerous, and those patients can be very sick. And then there's been really variable response in CCLA. There's been some reports of sirolimus helping and other reports of it having no effect at all. And it's possible too, because this is a really new diagnosis as well. It's really difficult to diagnose, that some of those with responses may not have been CCLA or other conditions, or it may actually have no response, since it's generally a dysfunction of those lymphatic channels. And moving on to the next ones, which is MEK inhibitors. There's more than trametinib, but I highlight trametinib because this is the one that is most commonly used in complex lymphatic anomalies. And it's an oral medication that's once a day, and it inhibits this RAS or MAP-ERK pathway, which does include the NRAS, KRAS, and HRAS, which I've listed, again, these mutations that are found in KLA, Gorham-Stout, and CCLA. This CBL mutation interacts with this RAS pathway. And as you can see here, it again just slows the pathway to the right and does not allow for the increased blood vessel development over or excessive cell growth. So again, has not been prospective studies looking at this, but it's underway. But there are multiple case reports of KLA that is successfully controlled with trametinib, even after they've failed or progressed on sirolimus. Dr. Foster published a paper. This is a patient who was progressing with KLA, who was progressing on sirolimus with a known CBL mutation, and responded very, very well, and is doing very well to this day with trametinib. And then there's also a few case reports that are published with improvement in CCLA. And as you can see, the one over to the right, who had quite a bit of edema in the lower extremities, still has some after treatment, but it is drastically improved. The one that there is not much data yet, but it is very hopeful and promising, is Alpelisib, especially for GLA. This is an inhibitor of PIK3CA. It is currently in a trial for these PIK3CA-related overgrowth syndromes, or PROS, which often have lymphatic malformations. And the PIK3CA mutations are also found in isolated lymphatic malformations. It's really a good potential treatment option for generalized lymphatic anomaly, especially if they are having no response to sirolimus or inadequate response. It's question whether Gorham-Stout, based on the new data of the KRAS mutation. And we also need to have cautionary use with KLA and CCLA, and I will discuss that in a second. So again, here's the slowing of the overactivation of the PIK3CA by Alpelisib, and that is the direct mutation that generalized lymphatic anomaly affects. So why I said that caution needs to happen is we know that in certain cancers, sometimes when you block one of the pathways, in this case would be blocking the PIK3CA. And if you had a mutation like KLA in the RAS, and the signal can no longer go to both PIK3CA or RAS, then if the PIK3CA is blocked, that extra signal would go over to the RAS, which is already turned on too much. So there's concern that it could potentially worsen that disease. This is a known phenomenon, unfortunately, that does happen in cancers, most notably in melanoma. So some future questions or studies that we still have, this is just a few, there's a lot to be studied, but it's an exciting time in the field, is that, what are the optimal doses, the length of treatment, and long-term side effects of these medications, specifically in our complex lymphatic anomalies. And then we need to determine what are the best combinations. We have ideas based on genetics, but from a biological standpoint, for each one and their different mutation, which is the best? And also, like I had just hinted at, what is the effect of the PIK3CA inhibition with the RAS mutation and vice versa? And I'd also mentioned that there are currently prospective MEK and other mTOR inhibitor studies and trials underway. And we also have questioned what is the role for the RAF, ERK. ERK is a kind of a holy grail targeted therapy in cancers. And so we wonder, whether it would be helpful. And then another one that we really didn't touch on today is angiopoietin 2 or Tie2 inhibition. And there's many more other questions as well. So that is the end of my presentation. I just wanted to thank the LGA for the continued support, as well as all of our patients and families and advocates and researchers who are working really hard to improve our knowledge of the disease and the treatments and quality of life for those with CLA.
Thank you, Kiersten. That was a terrific talk. And again, it's a really broad topic, and I think you covered that well. So thank you very much. I want the audience to remember, if you have questions, please put them in the chat, and I'll be happy to ask that. So, okay. So Michelle is asking, I've had a refractory chylous effusion or ascites for the past 17 months, which developed after surgery for a hernia. I have no quality of life, and yesterday I met with a professor who thinks the issue is my mesenteric lymphatics and described this as being an aggressive cancer that they can't treat. Is this the case? Is there anything that can be done if there's issues with the mesenteric lymphatics? I've been on Sirolimus for 3 months and it's made no difference.
So it sounds, obviously without having all the information and knowing what has been done in the past, usually when we see, and obviously I'll have to talk broadly, really bad chylous ascites or chylous effusions that are unexplainable in terms of a known malformation syndrome, KLA or GLA, we recommend lymphangiogram to be done to try to see where the leakage or the obstruction, because it's either the lymphatic fluid is supposed to drain into kind of our central veins, and it either can be dysfunctioning and not draining properly, or something is blocking it, and so that's making it back up, and that is one of the concerns in the belly. It is not generally I can't say for sure again, but this is not, when this happens, it's more or something like the CCLA phenotype that we see, and it is not a cancer. Sirolimus is worth a try. As I had mentioned, the CCLA, or central conducting lymphatic anomaly, has been found to have that FB4 mutation, or in one case an ARAF. So potentially that a MEK inhibitor could possibly help. Otherwise, but it may be actually a structural or functional issue that would need to be surgically correct. And that's what has to be determined with like a lymphangiogram.
Yeah, and Michelle just put in the chat, I've had a lymphangiogram and it was normal, but I think, as you and I know, that lymphangiograms are not all the same. And it depends upon, where you actually enter the lymphatics, whether it's internodal in your groin, or whether you can actually now do, mesenteric lymphatics and liver lymphatics. So there are different approaches to that. So
I would agree. And it is one of the very difficult to get this an appropriate or a good lymphangiogram. Not only is it technically difficult, but to make sure that it's the correct location, like you mentioned, and also the person who is reading and interpreting the lymphangiogram is also, the expertise is really important.
Yeah, and Michelle, I would be very happy to kind of help you with this and better understand your particular case, and offline. So I know you can contact us through the LGDA support, and I will definitely get back to you. Let's see, there's a couple more here. Sorry. You had technical difficulties starting. I'm having technical difficulties with the chat. Anila Morena asks, for a patient who is immobile for more than 6 months from GSD and the damage and damage to the bones, will sirolimus combined with Zometa help him gain the strength and get back up on his feet again?
It is so it is obviously it's not a cure. It depends. So it depends on why, what is causing the weakness. Is the bone actually just kind of broken down too much where it's dangerous, or you don't have enough support or stability to be up on your feet? But if there's a lot of pain and just generally, because it absolutely could possibly, and it also, that combination, like I said, to help decrease or hit any further bone loss. And like I said, both of them together is better than actually one of them. And that's actually even shown with Dr. Dillinger, his research, even in the mice in basic science as well. I think physical therapy with their understanding of what your limitations are and what you're at risk of is also extremely important.
I agree with both of those points. I think that physical therapy is a necessary part of any therapy that you initiate, and again, I think that we need to think with regard to combination therapies, particularly those that include bisphosphonates. The major targets of those different therapies are different. And so, one predominantly affects the bone, although not exclusively. And the other is a more general target that affects both bone and soft tissue. So, Edith asks, do you always recommend biopsy in a new patient with typical GSD on MRI?
That's a great question. I do not. In fact, it can be dangerous. So if it is a very typical case, age is also really important, because if we start, it's a new diagnosis in an older adult, we really do have to think of things that are actually more common, like multiple myeloma. But if it is a very typical, and we see so you've got the inside of your bones as well as the outside, or like the rind, so to speak. And Gorham-Stout breaks through that rind or the cortex, and that is very typical. So that is why I don't per se, if there's a clear diagnosis, especially if I find other lesions, especially distribution that's common with Gorham-Stout disease. I definitely do not advise against any biopsies of ribs or vertebra, if that's possible to avoid those. That can actually cause CSF leaks if it's the vertebra, or actually a pathologic fracture leading to spine instability, or the ribs very commonly actually end up causing, if you don't have them already, effusions or fluid in the lungs, and it can be very difficult to get rid of them once they're there.
Yeah, and I think that, Kiersten, there's also those diagnostic evaluation recommendations that many in your group have really put together, which I think is also a good starting point. And you highlighted really the important features of all of those. So thank you. I appreciate that. Let's see. One question is there Stefan, is there a rationale for using combination therapies for GLA up front versus single targeted therapies? So
good question, because I see that an example is adding Sirolimus to, let's say, Alpelisib. So that has been brought up a lot. But it's also the question, it's very similar in the sense that both of these, if you inhibit that cellular growth or development of new vessels too much, what will be the complications of that? These are important genes or signals in our body for other cellular processes. So you don't actually want to cause harm, by adding additive therapy. That is a concern that we've talked about a lot within our groups, and that we think needs to be looked at even from the more basic science level with animal studies before doing so in humans. I don't always use, especially if someone presents with a new diagnosis of GLA that is not in a progressive state or doesn't seem to be, who is doing fairly well. That's when we talk about, here are our options. Some families choose to very watch and wait, but closely monitor rather than start Sirolimus, and others do feel like they want to do preventative. And that would be a case for just using, like I was saying, monotherapy or a single agent Sirolimus to prevent complications from happening. I only add other things when we are uncontrolled disease. We're having a lot of complications, especially if they're significant and serious. That's when steroids come into play, or vincristine. KLA is another, it's a different beast in so itself, where it's often uncontrolled even when it presents. So.
And Kiersten, I've heard you and other physicians that take care of patients with CLAs really talk about the point that you mentioned, which is we're still learning about the short-term and long-term complications of monotherapy, and we have virtually no understanding of the acute or immediate or long-term effects of combined therapies. So I think that's a really good point as we kind of talk about targeted or precision therapies moving forward.
Yeah, and we know that when you combined to targeted, at least in cancers, that it can cause issues. So this is why a lot of us, think that we need to start with, our basic studies, or basic research animal studies to look at that. The safest thing to do.
And Carmen asks, my son, 17, has Gorham's and was on Sirolimus for roughly 9 months. And while he was on this, his lesions grew. Is this uncommon?
I guess that depends. I'm assuming it's bone lesions. is what I assume. This is, well, it depends on how it was looked at. I hope that it was monitored with the same type of imaging, because to tell you the truth, it really depends. It can look larger, smaller, depending if you're using CT, MRI from day to day. We can see that. I would be surprised. 9 months for bone changes. It's possible. Yes, I mean, we see this. I don't know what doses they were using either, especially if you're having progressive disease at the time. We would use the higher doses of sirolimus, potentially steroids, depending on what's, pain and things like that. But in another point is that bone changes are really slow on imaging, very slow. For example, cured multiple myeloma, which has similar appearing lesions, can take up to 56 months to even start to look better on cured cancer. So it's hard to say whether they were already at that stage, and then the imaging caught up, so to speak. I usually look at the whole picture. Like if your son was feeling better, having less pain, less fatigue, function improved, also in relation to what the lesions were doing on imaging.
That's a really good point. And again, I think traditional imaging of the bone is really hard to interpret. Sorry. And again, I think that I think this is a feature that not many people understand, is that the bone can look very similar for long periods of time after it's been damaged. So we need different markers of response other than just sort of CT and or MRI. Great.
And I agree. For Gorham-Stout, yes, I really hope we find this, and we're still looking. Just an example, it would be more along the lines of KLA, but Dr. Tim LaCroix and his group have been studying angiopoietin-2 and monitoring that in the blood of KLA as well as KHE with Kasabach-Merritt. But we've started using this clinically as well, because it's sometimes you can't tell, versus the imaging or even in person, if things look like they're worsening, flaring, but some of those biomarkers can be pretty sensitive to that, or just to tell us that our treatment is working. And yes, so we hope to find that for Gorham-Stout as well.
Yeah, and I think those are really important clinical trials and clinical studies that are ongoing that we need to encourage patients to participate in. So that's, again, a great example of how biomarkers can help us in addition to imaging and quality of life measures and looking at response of patients on therapy. So another question comes in, treatment with bisphosphonates in young women. Do you avoid bisphosphonates if possible, or how long do you stop before pregnancy, before the patient wants to try to get pregnant?
So I would say the institutions that use them for this indication, the protocols are very different amongst us. Ours here at Cincinnati is generally about 10 doses. We give a little bit of especially if it's progressing or worsening disease, and it's why we're starting it. We end up giving it monthly for 3 months, and then every 3 months afterward for 10 doses, and stop. At least we try to hold off for another 2 years because of the accumulation of that drug and that risk of jaw necrosis. But I know that Texas Children's, for example, they use it every 6 months for about the same amount of doses, or a few years. But it's different across the board. We do not avoid using in young women. We do, a lot of times they're on another medication, Sirolimus, MEK inhibitor, something like that, where it is also very important that pregnancy needs to be planned, because those medications could potentially affect the fetus. And so we generally advise at least 3 months, 6 months, because those medications can stick around for months in the system. But but we know that this is not always possible. And there have been reports of women, having babies without any issues who have been on sirolimus and these MEK inhibitors. So there just isn't great studies for it. We just say advise, sometimes there's other therapies that we can do with while a woman, has a baby. So I wish I had better answer for that.
Yeah, I think that's a really important point, and one that we hear a lot from our community is sort of the effect of pregnancy on their disease, as well as effect of medications on pregnancy. And I think, as you aptly point out, we have case reports and anecdotal experiences, but it's not been studied in a systematic way to date. So that's an opportunity. So let's see, one more question. If patients with GLA have progressive symptoms on sirolimus, low dose, but with side effects already on low dose, would you switch to everolimus or try to biopsy for mutation, or how would you approach that?
Good question. So depending, I guess it depends on what are the symptoms. If it's mucositis with really bad mouth sores on the tongue or inside the mouth, there's actually really good data now coming from the breast cancer world, where they actually, and we have found very helpful in our patients, is a dexamethasone mouthwash, actually, that can be preventative when you're increasing dose, or used kind of intermittently when you're getting them. And it really works and heals up those mouth sores within days. And it can even, for those who have difficulties increasing, prevent these from happening. Now, other side effects, I think it is, yes, definitely an option to everolimus. We've had people who have had intolerable acne or GI symptoms or headaches with, or even kind of mood, psychological issues with sirolimus, and then switched over to everolimus and done very well. Depending on, I guess, where some of your lesions are, in terms of accessibility for biopsy, is definitely an option as well. But I will say that I would look into your insurance coverage. It's one of the downsides of all of this, is that genetic testing, not all of our medical insurance covers it, and it can be up to $5,000 or $6,000 if paying out of pocket. There are obviously some groups that can sometimes help fund this, and because it is a very important point to make, that if we're not responding to therapy, is it because we have a different a different medication be better for you? But I think everolimus would be the first way to go.
Okay. And then a final question: what is the starting dose of sirolimus that you would preferably start on a patient with GSD?
This depends on age, size, I guess tolerability, what other medications they're on, other issues that they have in terms of like function of organs and things like that. So we take that all into account. In the paper, it's 0.8 per meter squared, but honestly, there's studies that are actually out of Cincinnati children that have looked at the different doses that need to happen in infants, children, and older children and adults. That is based on which level that we want. If someone has Gorham-Stout, in general, we're trying to hit level or trough levels of around 8 to 12. I would say the vast majority of us use. That can even go up to 15 if we're having lesions that are continuing to progress or worsening pain. Everyone metabolizes drugs differently. So these dose recommendations that are in all these papers are starting doses. And it's really about increasing and decreasing. Usually it's like 20-ish% when you're making these adjustments to get into the right level. So there are I would say there's a lot of monitoring in labs at first with it. At first, though.
Well, Dr. Ricci, I really appreciate your time today and helping us educate ourselves and our community with regard to CLAs and the new therapies and the therapies that are being used currently. So I really appreciate that. And for the community, we will post these educational webinars on our website at LGDA, and we'll share them through social media. So please be on the lookout for those once we've had an opportunity to edit the current one. We'll get those up on the website soon. So, all right. Well, thank you again, Dr. Ricci, and again, thank you to our all of our participants. And we really appreciate your time and the thoughtfulness of all the questions that were asked. So thank you.
Thank you, guys.